Section here is going to be looking at the knee to wall test. Now you can do this as the first part of your assessment or after the table test, whatever works for you with how you're setting up your movement screening and overall assessment. Now what I want to focus on here is I actually have Crystal in a half kneeling position. The reason I think this is important is if somebody's in a standing position, they're much more likely, I find, to often rotate over their leg. They could come up like this and kind of cheat the knee to wall test. Now, of course, you can do it in standing and just be aware of that, but half kneeling makes it just a little harder, but it's still something we need to look out for. So, knee to wall test, often I'm gonna get the individual to start pretty close to the wall, maybe just an inch or two, or 2 to 5 centimeters. I'm just gonna get a sense of how well do they move as we try to touch the knee to the wall. Making sure that their pelvis position is pretty square and that they're not getting this kind of scoop over effect. They're not getting a big valgus through the knee. And also just kind of checking out what's happening at the foot. As we talked about with the prone dorsiflexion test, a lot of times people that have a stiff talocrural joint might end up moving a lot through the foot. Might not be a bad thing, but just when we're adding things up for the entire story of that patient and their case, we just want to see, are they having a large kind of collapse or flattening through the foot, or are they not getting anything at all and they're just holding rigid? So taking a look at the foot, making sure the knee is tracking well, kind of straightforward, right over the second toe we often say, and making sure the pelvis position is square. So now as they rock forward, making sure we're not getting those compensations. As they successfully achieve a knee touch to the wall while maintaining their heel down, I am now going to get them to move back just a little bit. Oftentimes I'll say just a centimeter at a time, and the patient might end up jumping like 3 inches because they just aren't grasping it in the moment, and then I'll try this next level. Good, and then come back just a centimeter, very small. And then we're just going to keep going back until we have that objective measure. I don't